don't know if that's the cause or the consequence. Supraspinatus tendinitis, for example, when you make ultrasound, you see, okay, rupture in the supraspinatus tendinitis. Okay, that's, we need to, when you make an MRI scan, the doctor says, okay, we need to saw it together. But we have a muscle here, subscapularis, or subclavius, which is pulling the clavicular down. So the supraspinatus get pinched, and by pinching there, you can get a rupture. So they can saw it together, but it comes back. You see, for example, with football players, they have a meniscus injury, they operate, and then maybe after 3 or 1 year, they have the same meniscus, they operate for 3, 4, 5 times. That is not the cause, that's a consequence. We want to find out what is the cause, and then when you treat, it stays. So when a patient has a score above 18, meaning dysfunctional breathing, it could be a lot of things. That's why above 18, they fill in the CSI, Central Sensitivity Inventory. Also a scientific list. It's the same, 0 points, 1, 2, 3, or 4. And then you count this all up. So on the green level, that's normal. So some patient you will see, it's, let's say, 50 or 60. So it means the brain is more sensitive. Now is the question, when you have a high score here, when the brain is more sensitive, you breathe higher. But the other way around, when you breathe higher, your brain is getting more sensitive. So then, what is the cause, what is the consequence? Because when your brain is more sensitive, you sleep, and I do this, you wake up. And then you say, oh, it's sleeping disorder. It could be also from the breathing. So it's all connected. So you want to find out what is the source. So this we feel in standard. Only this when the NIMAX is higher than 18. Yes?
Actually, I do it with all my patients. I send them this form before they come, so they fill it out. Because all pain, of course, consists of 2 elements. One, issues in tissues, and the other element is the sensitivity of the nervous system. It's always, with every pain, whether it's acute or chronic pain, it's always these 2 things. And with this CSI, you know how sensitive the nervous system is. So then you can relate these two. So you can also then you start off with your patient from the beginning, on the right page, because if they come with a lot of pain, but they have a high score on central sensitivity, then you can say, okay, big part of it is the central sensitivity. So we have to look at stress, sleep, nutrition, all these factors, breathing, that influence emotions, cognitions, everything that influences the sensitivity of the nervous system. That's not only breathing, but it's of course all the other different parts. If you first start treating a patient, the issues in the tissues, and you don't really get the results you want to get, and then afterwards saying, oh yeah, but maybe it's your nervous system, or maybe there are psychological reasons, then people start rejecting it. But if from the beginning you say, okay, this is what I found in your body, trigger points, fascial restrictions, and this is what I found in your nervous system, then you know where to go with your treatment. And very often, especially with chronic pain patients, you have to do both, treat issues in tissues and treat all the factors that influence the central sensitivity.
Always keep in mind, Ernst is working also a lot with chronic patients. Only with chronic patients. I'm more in the private practice, so I see few chronic patients, but more sports related, or more people who are falling from the stairs at their home. So I do this only when this is higher. But when you see, yeah.
But how we, as kinesiologists, can resolve the problem with the central sensitivity?
We can do very well. But that's, maybe we talk about that in the break, because I can explain, but that's going away a bit from the story now. But
your breathing techniques, you have different kinds of techniques. And also,
Because I really have patients who score 73 or even a few weeks ago 81 on the central sensitivity. That's really extreme. But I can explain to you how you can treat it as a physiotherapist. But sometimes, of course, you need, if someone is traumatized, especially when there is sexual trauma or childhood trauma, of course you have to refer to a psychologist or to a psychiatrist. You cannot do everything. But
you can include in your program relaxing exercises, playing with...
You can do a lot of different things. But of course, you have to be aware if there's really a traumatized person. But that's the nice thing, because you know it right from the start, before you start your treatment. And that makes really different approach, difference to the patient than only coming after 2 or 3 weeks or 10 weeks, and then you say, oh, no, I think it's more psychological. That doesn't work.
They have to accept this.
Yeah.
Yes, because
But
in the beginning, what you do now is a baseline measurement. So in the beginning, when you come in, you have a baseline. So it doesn't matter when you say, okay, I want to do this treatment or this, because when you do your treatments, maybe after 4 or 5 sessions, you can do the measurement again.
Yeah.
And when you scored here good, then you know, okay, this treatment for this patient suit well. Because the problem is, there is no treatment one size fits all.
Yeah.
That's why with this you can analyze. And also the other thing is with this, because when you see, okay, this is a high score, let's say stress, tired, this is high score, and this is a high score, then you say, okay, there's all negative elements, which is influence your healing process. But for example, when this is high and this is high, it's mostly always certain there's also psychological problems connected. And then you say, okay, this is more for me to treat. I refer to someone else who specializes. It's up to you. But then in the beginning, you have your baseline. Even I do a lot of sports, we do always this. Okay, then you do a global inspection. How's the posture? How does the patient stand, just relax? How does the patient stand? Is more in this position, more upright, more standing on one leg, is fragile, is more athletic. But you probably all already do this. Okay, the myofascial lines can you help with your inspection. When he's pulling more on this side or pulling more on that side, the patient has a tendency to stand more this or maybe more with the torsion of the trunk. But you must always keep in mind, fascia is a relatively new, not officially discipline, but relatively new. So it's still in developing. So that's why myofascial lines in the beginning can help you to sort out, okay, where could be the problem. Then you have another form you can see for your inspection. For example, there's more torsion of the trunk. You can make errors, more a lateral shift. So then you see an overall for your file forming for your patients. How was the position of the pelvis, of the scapula? It's more elevated, it's more depressed. And also look at scar tissue. Sometimes you see small scar tissue, but it's like when I pull here my shirt, when it's tight, it has consequence for my arm. So the fat and the wetsuit, it has consequence for movement elsewhere. This is one of my patients. When you look in the distance, you think, hey, it looks normal, but when you look a closer look, you see the fascia here, the skin, is different. And this is a patient of mine, it's 80 years old, artificial hip on this side, and get a new knee. But when this is tight, your movement is almost none here. So when you don't have movement here, what do? You move more with other parts. So when you move more with other parts, you get quicker arthrosis. then the question is that the source or is that the consequence? So the difference between functional assessment, what we do, and goniometry, local, is when you do locally, you miss a lot of points. Only when you do when you do functional, you miss a lot of points. Only the problem with locally, you can do it more accurate. But on the other hand, what is accurate? Because when you do goniometry 3 times, you have mostly 3 times different angles. So that's why we prefer to do it more globally. We have a scale how you can fill it in to score it. But the problem is it's not very accurate. But what we want to do with our assessment is first total look. Then you see, okay, everything points to this way. You can treat local, and then you can move total. And that's the problem with when people say, okay, what we want to find out is your pre-test and your post-test. That's the most important thing, because theory through the ages changes. But what always stands is your pre-test. Well, patient come in, I cannot move like this. You do your treatment and do the test again, and he can move. That's the only thing what counts. This will always stay through mankind. Pre and post-test. This is an example when the patient does only local movement or a total movement. It's in Dutch, I will translate. So when he does this movement, is pain in that region. Also pain there. So when you do the local treatment, no problem. He feels in the chest. So that's the difference between normally in the beginning when I came from school, we do this the standard, exo-endo rotation, but now we do more functional testing. Because the problem is, for example, low back pain can come from the fascia plantaris. But how do you want to filter with your local lower back assessment? Okay.
Can you go back?
Yeah, this is our motto. So to test the whole thing, we develop an assessment where you can do the whole body in less than 10 minutes. And in 10 minutes, you know, okay, there's a problem in the neck, there's a knee problem, there's a problem in the shoulder, it's restricted. And then from there you can work. Okay, this is the assessment form. So, cervical, shoulder part, spine, legs, and these are functional tests. But today, in this module, we only focus on this part. Cervical, shoulder, a piece of spine. So, what you can test here is the function, how they perform. So it says about the mobility, stability, strength and coordination. In this part you fill in the sensation, what the patient feels. Pain, pulling, or something else. And here you put the remarks. I will go more into it. So when you have a patient, for example, one of the tests is bring your chin on your chest, and it's very restricted, you put figures in. I will come on the next slide. And here you fill in the sensation patient feels. But this, what you fill in, is this sensation, how the patient describes it. Because mostly when the patient brings the chin on...
Can you make a little bit bigger.
Yeah, that's why you can go to the next slide because
Okay, this you
it will
do
come
in
in a moment.
you do this in the full assessment the first time, beginning of the test, and then the second time when it comes, you don't fill the whole form. You see, okay, this gives provocation. We test it. It's still better. Then you continue with your treatments, and you get a global overview. So test, treat, and retest. So what you saw here in the functional part is you rate it like this. Bring your chin on your chest. When it's almost not possible, let's say one finger, you should touch your chin on your sternum. When it's almost possible or not correctly performed, it's scored 1. When it's extreme restricted, so I bring my chin on my chest and only come like this, extreme restricted, it's a 3. And all between that, that's a 2. And the biggest discussion always is, what is the border between 1 and 2 or 2 and 3? For us, it doesn't matter, because when a patient comes like this, you do your intervention and then you touch us there, it doesn't matter where the border is. A minus tells you about the hypermobility. A little bit hypermobile, extreme hypermobile. Yes? Till now clear? The grading? So 1,